evening and welcome to this evening's meeting on the Standing Committee of Social Development. My name is Caitlin Cleveland. I'm the chair of Cam Lake, and I'm also I'm the MLA for Cam Lake and also the chair of this committee. Today, the Standing Committee on Social Development and Government Operations are holding a joint public briefing with the Department of Finance on health recruitment and the Department of Health and Social Services on the health and social services system sustainability. This meeting is being live streamed on the Legislative Assembly's social media channels, and I would like to, before we get started, remind all members and witnesses to direct all questions and comments to myself as chair, and wait to be recognized so that we can ensure that your microphone is turned on and all members of the public are able to hear the important information being shared here this evening. If there is anyone in the room that wishes to speak during this hearing, please speak with our committee staff and they'll make sure to put you on the list. But before we get started, I'd like to give members the opportunity to introduce themselves. And I'd like to start with the member to my right, please.
I'm Katrina Knockleby. I'm the MLA for Great Slave.
Thank you very much, Emily Knockleby. I would now like to turn it over to the chair of the Standing Committee on Government Operations, Mr. Ryland Johnson.
Mr. Johnson, can you hear us?
So we are joined by MLA Ryland Johnson, who's joined us virtually. And with that, I'd like to pass the floor over to Emily Bonnet-Rouge.
Ron Bonnet-Rouge, MLA Detro. See.
MLA Jericon. Are also joined by Emily Jericon as well, who has joined us virtually. And with that, thank you very much. We also have in the room with us this evening Nigel Woolridge, who is the committee advisor for government operations, Mahalia Yaklaya Newmark, who is the advisor for social development, and committee clerk Cynthia James. With that, I'd like to pass the floor over to yourselves to please start with introductions for the record, and then with that, I would like to invite you to start with your opening remarks and your presentation. Thank you so much.
Thank you, Madam Chair. My name is Bill McKay. I'm the Deputy Minister of Finance. With me here today are Colleen Wellborn, who is the Manager of Health Recruitment Unit. So she's to my left. And on my right is Deborah Ross, who's the Director of Management and Recruitment Services. So they have oversight over the Health Recruitment Unit. And we'll be delivering a presentation to get things started off. During the presentation, we'll outline the roles and responsibilities of the Health Recruitment Unit and provide you with a summary of the work to date. We'll also demonstrate how the unit's efforts have led to a 15.9% increase in the number of healthcare professionals in the NWT. Just as a reminder to the committee, the Health Recruitment Unit was established in August of 2020 to support the mandate to increase the number of healthcare professionals in the NWT by 20%. So, Madam Chair, if you're all right with it, I will pass this over to Colleen to give the presentation that she's prepared, and it's up on the screen. Thank you.
Absolutely. Thank you so much. The floor is yours.
Good evening, Madam Chair and honorable members. Thank you very much for having us here tonight to present on the progress of the Health Recruitment Unit. We can switch to slide 2. In this presentation, we will talk about what we do, who we have hired, who we are hiring, as well as challenges and opportunities. Next slide. The Health Recruitment Unit was created to be strategic, targeted, and efficient at hiring hard-to-fill healthcare positions. The HRU is a streamlined team focused only on recruitment and how to continuously work to improve on recruitment. This team is comprised of experienced recruiters who are able to respond and adapt to various changing needs. The HRU works to break down barriers and find creative and quick solutions to solve staffing issues throughout the Northwest Territories Health and Social Services Authority, or NTHSSA, and the Toledo Community Service Authority, or TCSA. Next slide, please. In order to effectively recruit and retain top healthcare talent, Health Recruitment Unit, composed of 8 HR professionals, was formed in 2020 to focus on hiring hard-to-fill positions. This team has 1 manager, 1 human resource assistant, and 6 recruiters. One recruiter is based in Inuvik and one is based in Fort Smith. The HRU is in addition to the full human resource services that the GNWT provides to all other departments and public servants. HRU hires nurses, mental health professionals, and allied healthcare positions throughout the Northwest Territories. In addition to HRU, Management and Recruitment Services also has the following resources dedicated to recruitment efforts for the Northwest Territories health system, totaling over 20 employees. The Client Service Team for Health and Social Services, the Client Service Team for the TCSA, the Client Service Team focused on the NTHSSA, YK Region and Territorial Ops, the Client Service Team for NTHSSA Stanton Regional Hospital, as well as the Human Resource Client Services in the regional offices who provide support to NTHSSA. Next slide, please. In order to maximize the resources of the HRU, a recruitment-specific position list was developed with all key stakeholders. The hiring mandate of the HRU is tied to two specific questions. Is there specialized health skills or education required? And is this a client or patient-facing position? The goal here is to have a dedicated unit focused on recruiting specialized hard-to-fill positions that have a major impact on the care of NWT residents. Many important positions, such as the personal support workers or admin support roles, aren't included as the education required isn't considered specialized healthcare. Similarly, most management roles are not included as those roles, while important, do not impact the day-to-day care that residents require. The list of positions that HRU recruits for includes all nurses, social workers and counselors, lab technicians and diagnostic imagers, midwives, and rehab service therapists. Next slide, please. Sorry, next slide, please. Oh. Next one with the colored capes. That's it, yep. Thank you. As a specialized unit, the HRU has specific roles and responsibilities targeted at hiring strategically and typically hard-to-fill healthcare positions. The success of the HRU is dependent on working closely with stakeholders and healthcare managers. The first step in this process is to clearly define how our hiring processes work, determine who is involved, and how we can work to break down barriers. These processes are clearly defined and communicated to healthcare staff to ensure the unique challenges of health are dealt with accordingly. HRU also focuses on collaborating closely with all levels of healthcare providers. HRU participates and sits in on various groups and meetings at the facility, departmental, regional, and territorial level to ensure all stakeholders have a strong line to HRU and that we have a clear understanding of concerns and challenges facing the health regions. Reporting is an important function that HRU constantly assesses. We analyze significant amounts of data to ensure we are meeting and improving on measures around the number of hires, both indeterminate and casual, the time it takes to hire, and vacancy rates throughout the territory. Next slide, please. The HRU manages a casual nursing database comprised of over 300 nurses throughout the country who are interested in working in the NWT. While running competitions is how we aim to fill positions permanently, many short-term vacancies need to be filled to cover vacation or short-term leave for employees. Each month, the HRU works with managers to determine upcoming short-term needs. Once those have been collected from all regions and facilities, HRU will do a call-out to those healthcare professionals in our database who have registered for work opportunities. This process is time-sensitive and involves a great deal of correspondence and follow-up. These short-term coverage requests also arise in urgent situations where HRU is required to shift their focus to this database to find immediate coverage and maintain service. HRU also utilizes the services of the Practice NWT team. Practice NWT is a division within the Talent and Organizational Design team, also known as TOD, within NTHSSA that supports and promotes careers in health and social services for all 3 health authorities in the NWT by highlighting how the NWT is a great place to work and live. They develop specific marketing campaigns for our hard-to-fill competitions and promote them on their social media channels. They also have a variety of internal health programs, such as the Professional Development Initiative, or PDI, and Specialized Nursing Transition Program, SNTP, that can act as an effective recruitment and retention tool for healthcare professionals. Next slide, please. Following the challenges of COVID-19, another way that HRU maximizes our talent pool is by attending career events throughout the country. NTHSSA's Talent and Organizational Design team communicates regularly with HRU, providing notice of upcoming career events and invites a recruiter from HR to attend. The focus of these events is to attract and promote working in healthcare in the NWT. There are various presentations and marketing material that has been developed in order to promote this message. Over the last 3 years, HRU has worked closely with Todd at various recruitment events. Since 2021, HRU and Todd have worked with Aurora College and their students to promote job opportunities and expedite hiring for successful graduates. HRU accompanied a Stanton Critical Care Manager and ICU nurse in attending the annual Canadian Association of Critical Care Nurses Conference in September 2022 in Windsor, Ontario. This involved delegates ranging from registered nurses, clinical coordinators, and clinical educators, all working in the ICU and ER. HRU attended the Acute Care Health Expo in October of 2022 in Yellowknife and engaged with Aurora College nursing students, as well as grade 10 and 11 students. HRU received a high amount of interest from all students. HRU also attended a virtual Canadian Association of Midwives conference on November 3rd, 2022. However, the number of participants was less than expected, and there was a lack of interest from the attendees. HRU members attended the Aurora College Research Day on November 30th, 2022 in Yellowknife and engaged with Aurora College students. Approximately 200 people attended overall, including instructors, students in the first, second, third, and fourth year nursing program, licensed practical nurses, and personal support workers. HRU received a high amount of interest from these students. HRU also accompanied delegates from Todd in attending a career fair at the University of Manitoba in January in Winnipeg. HRU attended the ER Rural Hospital Conference in Banff, Alberta on January 20th to 22nd, 2023 with the manager of critical care at Stanton and Todd. This conference provided the opportunity to engage and discuss possible recruitment with registered nurses in the emergency unit. HRU also sent a member with Todd to a career fair at the University of Alberta in February, as well as attended the 2023 Canadian Association of Perinatal and Women's Health Nurses National Conference in April in Winnipeg, Manitoba. Further planning is underway for continued participation at conferences and career fairs. Next slide, please. Now that we've talked about who we hire, I'm going to describe who we have hired. The Health Recruitment Unit has been working since its inception to clearly measure and report on our progress. These reports are generated to gain insights into the value and effectiveness of our recruiting process and ensure we are responding and changing when necessary. The following slides and Appendix A will provide hiring data over the last 3 years. Next slide, please. First, a note on reporting. HRU has developed and used the same reporting criteria and metrics since its inception in 2020. However, there are a few notable differences in the way that HRU reports as compared to Health and Social Services. There is no right or wrong way to report, only different departments with different recruitment tasks. With respect to the time period, HSS measures between June 30th, 2019 to June 30th, 2023. HRU didn't exist until 2020, so our measurable time period is from August 1st, 2020 until June 30th, leading to a difference in over a year of data. Health and Social Services includes the Hay River Health and Social Services Authority as part of their 3 authorities, whereas the HRU only staffs for 2, the NTHSSA and the TCSA. HSS only measures employees with an NWT address, which would not include all job share employees. HRU includes these staff as they spend 50% of their time residing and contributing to the economy of the NWT. Similarly, some job shares are Northwest Territories residents. HSS includes personal support workers, whereas HRU does not. These are not deemed as specialized medical education, so are not staffed by HRU. HSS includes physicians, whereas HRU does not. As far as exclusions, as noted previously, NTHSSA does not include all job shares, and unbudgeted positions are excluded by HSS. HRU does not make this distinction, as numerous unfunded positions may have ongoing competitions and/or are staffed. Next slide, please. In August 2020, there were a total of 786 resident healthcare professional employees with NTHSSA and the TCSA. In the last 3 years, HRU has hired 579 employees into the health system. Due to staff turnover, not all of these 579 are still in the same positions, but there has been a significant number of staff hired. Please see the numbers for each job category in Appendix A, but keep in mind that this is over 3 years and there is a notable level of staff turnover. The NTHSSA and TCSA have 15 speech-language pathologist and audiologist positions and have hired 14 staff into those positions since August 2020. There are 27 medical lab technician and technologist jobs within the system, and HRU has hired 37 over that 3-year period. HRU has also hired 44 community and social service workers, as well as 63 social workers. HRU has hired 284 registered nurses since August 2020. A regional breakdown of these hires is also included in Appendix A. It should also be noted that relief employee hires include those employees who have left an indeterminate or term position and have been hired into a relief role. Next slide, please. In August 2020, there were a total of 786 resident healthcare professional employees with NTHSSA and the TCSA. In June 2023, there were a total of 911 healthcare professional employees, up from the 786. This amounts to a 15.9% increase in the workforce. It's important to note that there were a large number of new positions created and that there is often more than one employee who occupies a position. For example, a job share position is 2 people filling the same position, but not at the same time, usually on a rotational basis. However, from a purely recruitment and hiring standpoint, the HRU has successfully increased hiring by 15.9%. Next slide, please. And now we'll move on to who we are hiring now. The HRU runs various competitions as requested by managers. These competitions are on our GNWT career site and are linked to various other social media sites and platforms. Given the ongoing challenges and changing environment, HRU runs initiatives that are meant to respond to the needs and interests of both applicants and managers. The following slides will highlight current projects being run by HRU. Next slide, please. As part of the HRU mandate, the team has worked on identifying and eliminating roadblocks for hiring indeterminate staff. After working and listening to managers within TCSA and NTHSSA, HRU proposed a change to the way that competitions are run and managed. Rather than run single competitions for every vacancy, it was proposed that similar roles or positions be grouped together and run as one large global competition. The goal of this new approach is meant to streamline the entire hiring process for all involved. For example, there's currently a global posting for all registered nurses for Yellowknife, Fort Smith, and Inuvik. This global posting has numerous benefits. For the applicant, applying on numerous separate RN job postings can be confusing and time-consuming. Many applicants give up before they finish their application or found the competition they're looking for. By running one registered nurse posting with various specialties listed, applicants can apply easily and be considered for all open positions. From a hiring manager perspective, the time and effort involved in running a competition is extensive. There are pre-competition meetings with HR staff, interviews, reference checks, administrative forms, contracts, etc., all of which are on top of their day-to-day jobs of running healthcare operations. In order to alleviate some of this recruitment burden, a technical expert who is a practicing healthcare professional has been appointed as a team lead. This team lead calls applicants and does pre-interview screening, conducts interviews and references, assesses suitability for certain positions and/or communities, and handles much of the administrative work required to complete a hire. The team lead provides a consistent and reliable presence on the hiring committee, ensuring that managers can be confident in those that are selected. From an HR point of view, the number of competitions is significantly reduced, allowing recruiters more time to focus on hard-to-recruit positions. Similarly, recruiters aren't competing against each other to hire the same applicant and are able to provide a more strategic approach when assessing candidates. The expertise of the human resource officer is fully utilized when they are able to assess all registered nurse resumes and assign them to the right area based on factors such as specialty, departmental vacancy, or experience level. From the marketing and advertising point of view, a global competition allows for better use of time and budgets. Combining the advertising budgets for several competitions results in a larger potential investment reaching a wider audience. Next slide, please. Global competitions are currently being run for a variety of positions. While there are a number of competitions ongoing that include various positions, I will touch on a few of the more successful global competitions and the resulting hires. Public health nurse, nurse in charge, and nurse practitioner for Betchico is a competition that has resulted in 3 new hires: 1 public health nurse, 1 community health nurse, and 1 nurse in charge. The public health nurse and nurse in charge positions had been vacant for 2 years, and the community health nurse position had been vacant since November 2020. There's a community health nurse competition for multiple term, indeterminate, and job share vacancies for all communities in the NWT. The competition went live in May and has resulted in 6 community health nurse hires: 3 in Toledo, 1 in Norman Wells, 1 in Fort Good Hope, and 1 in Fort McPherson, as well as 3 casual community health nurse contracts. A registered nurse competition for multiple term and indeterminate vacancies in obstetrics, float pool, medicine, surgery, and acute care in Yellowknife, Fort Smith, and Inuvik was also posted in May and has resulted in 2 new hires and 12 casual contracts. The average time across the GNWT to staff a competition is between 8 to 10 weeks. With the current global competitions for community health nurse and registered nurse, the average time from application date to verbal offer is less than 4 weeks. Next slide, please. Casual contracts are an important part of the GNWT workforce. These staff are employees of the health system and fill many positions that might otherwise sit vacant. Nurses throughout the country are looking to explore opportunities through travel and short-term contracts, and the GNWT has adapted to maximize these resources. In June, the Health Recruitment Unit processed 61 casual contracts throughout the territory. Oftentimes, casual staff use the opportunity to assess their interest or fit with a position and/or community. These short-term contracts often lead to permanent full-time work, and between January 1st, 2023 and June 30th, 2023, 19 staff that had previously been casual accepted indeterminate work with NTHSSA and/or TCSA. Next slide, please. Hiring is occurring all the time in HRU, and this list is meant to highlight some major areas of success over the last few months. In the Beaufort Delta, 2 community health nurses have been hired in Tuktoyaktuk and Fort McPherson since May of 2023. In the Sawtoo, 5 community health nurses have been hired in Toledo, Fort Good Hope, and Norman Wells. In the Decho, both Fort Liard and Fort Providence have had new family and community social workers hired in the summer of 2023. In April, Fort Smith filled a medical radiation tech position that had been unfilled since August of 2020. As of July, all indeterminate supervisory and medical lab technician and assistant positions are filled at the Stanton Territorial Hospital Lab. In February 2023, 5 obstetrics LPN positions were created to assist with the staffing challenges on the OBS unit, and all have been successfully filled. Both Fort Resolution and Little Cay have had a new community health nurse start in the spring of 2023. As of July 2023, all LPN positions in both the Frame Lake Clinic and Primary Care Clinic are filled. 3 community social service workers were hired for TCSA in early 2023. As previously mentioned, there's also been an additional community health nurse, public health nurse, and nurse in charge hired for Betchico in the spring of 2023. In total, 579 healthcare professionals were hired by the HRU from August 2020 to June 2023. Next slide, please. Moving on, we'll now look at our current challenges and opportunities. Hiring in healthcare is challenging throughout the country and even around the world. The labor force is constantly moving and changing, and it takes work and dedication to stay current in the market. We have unique circumstances in the North, and HRU works to identify our challenges while maximizing our potential opportunities. Next slide, please. One of the ways that the system has adapted to shifts in the labor force is by allowing flexible work arrangements like part-time or job share agreements. This means that employees may be filling the same position, but not at the same time. Another way in which the NTHSSA and TCSA have acted to support their staff and the system as a whole is to create a number of new positions. These new positions are also meant to better serve the people of the Northwest Territories. Since 2020, 126.5 full-time positions have been added to the system, 62 of which have been added in the last quarter alone. This increase in positions effectively adds 15% to the overall vacancy rate. This additional 15% vacancy in new positions offsets the gains made in hiring. All this to say that while the vacancy rate appears to have increased, the total number of staff in the system has also increased from 786 to 911. Next slide, please. While hiring has increased 15.9% in health recruitment specific positions since 2020, the number of employees leaving their positions is significant. The pace of hiring has not offset the number of exits, resulting in the relative lack of change to the vacancy rate. Exits are those that retire, resign, terminate, or transfer to non-healthcare roles. In the appendix, the details of this are noted on the second page. The net gain in these specific positions doesn't capture transfer assignments within the healthcare system or extended leaves such as maternity, parental, education, and sick. When exits are factored in, the net gain in positions decreases significantly. For example, the net gain for head nurses and supervisors was -7, yet registered nurses saw a gain of 68 staff. Licensed practical nurses saw a net gain of 27, and community and social service workers saw a net gain of 25. Next slide, please. There are many reasons that healthcare staff choose to leave their positions or the system in general. There are common themes that indicate that the stress and workload of COVID-19 has had a long-term effect on staff's physical and mental well-being. This is not unique to the North. Statistics throughout the country indicate many healthcare professionals are choosing to leave the profession entirely and pursue other job opportunities. That said, the health and social service system has worked to increase resources as outlined in the NWT Health and Social Service System Human Resource Plan for 2021 to 2024. There are many initiatives such as the increase to positions in support and care roles and increased funding and professional development opportunities such as the TASP, PDI, bursaries, transfer assignments, etc., that are encouraging staff to remain in healthcare roles. Nurses in particular are choosing where to live and when to work. The time of employees sticking to one job or field for 30 years is no longer. While wages are competitive nationally, relatively high incomes don't always offset the cost of living. Many state that they can get more bang for their buck down south. The labor market supplement introduced in 2022 is a significant financial investment in both recruitment and retention that is meant to offset the cost of living and recent inflation. Post-pandemic, many employees have stressed the importance of being closer to extended family. Wanting to be closer to aging parents or grandchildren are often reasons for staff in northern communities to move south. As mentioned, Health and Human Resources are working together to attend career fairs and student events to highlight the uniqueness, beauty, and advantages of living in the North. Community profiles are also being updated to provide prospective applicants with information on the full life experience of living in NWT communities. Next slide, please. The HRU has been successful in increasing the number of healthcare professionals by 15.9% by remaining focused, strategic, and adaptable. The HRU remains committed to listening to and working with healthcare staff and management, as well as prospective applicants, to ensure that mutually beneficial employment within the NWT continues. Continued focus on the recruitment of healthcare professionals is necessary to ensure continuity of service as we move forward. Wasi Cho. Thank you, Madam Chair and honorable members, for your time this evening. This concludes the formal presentation.
Thank you very much. Thank you for the presentation. I'd like to start off right away by opening the floor to members with any questions or comments for the Department of Finance this evening. Emily Knockleby.
Thank you. That's what you get for being in the room. You get to go first. So my question is, overall, this is sounding fairly positive. I do know that I'm glad to see at the end of the presentation this sort of acknowledgement of the loss of or the exit of healthcare professionals, and really noting that that is the biggest thing that I'm hearing currently as an MLA, as people wanting to leave, and a lot of the healthcare professionals being stressed about what's going on at the hospital. And recently, one of the comments that's being made is the time that it is taking for people to be made offers and from the time that they've applied. And this includes students that have left, they're from the Northwest Territories, they've gone to get, say, a nursing degree in the South, and then they've come back and they're still waiting on a written offer weeks and weeks later. So I note that it says that the average is under 4 weeks, but considering that in other parts of Canada, people are getting offers within a week, days even, the verbal is coming in immediately. I'm just wondering what the HRU or the unit or the department is doing to get that number down. And while I acknowledge that might be quick for us here in the north in the GNWT, it's not quick comparatively to the rest of Canada. So I think that's a big factor why we're losing on talented people. So if maybe someone could speak to that and sort of how are we getting that more streamlined, if that's the goal of these global competitions. Thank you.
Thank you, Emily Knockleby. Deputy Minister.
Thank you, Madam Chair. So as the member noted, the HRU does have a significantly less turnaround time, I guess, than the rest of the government. So we are working to improve that, but do take the point that you need to be pretty nimble in this market to be able to get professional healthcare professionals. So something that we're always working on and working to reduce the turnaround time on those competitions. That's part of why the HRU was set up, and they put in place many procedures that we've outlined just in that presentation that are reducing that time.
Thank you, Deputy Minister. Emily Knockleby.
Thank you for that. I guess I was hoping to hear some more actual actions or things that are being done to do so and to increase that, such as streamlining applications or, and actually I'm not going to profess to give any examples right now because I'm not an HR recruitment professional. I guess my next question then is around the job fairs. There's a lot of note in here about fairs that were attended and interest that was shown, but how is the department or the unit, measuring how successful that is? It's great to say that people show up and they have an interest in the unit, in the Northwest Territories, but if they go into the black hole of never hearing from us, or, how do we actually show that going to the career fairs is leading to actual employment and tracking that so that we can be more effective in using that as a tool? And I think that's a great place to get people for the North because they're young and they're adventurous and they want something new and different. So thank you.
Thank you, Emily Knockleby. Deputy Minister.
Thank you, Madam Chair. I might just turn it over to Colleen because she goes to these job fairs and has a lot of experience talking to people there, so I might turn it over to her for some insight.
Thank you. Earlier question about the duration. Just to be clear, when we're talking about the duration, we're talking about from the date an applicant submits their resume. So they submit their resume, we get in touch with them the very next day, the same day if possible. That first conversation usually is sort of what we would call pre-screening. So we assess how interested they are, what their specialties are, what their experience may be. It's on their resume, but oftentimes in healthcare you need further information. Then from that point we set up an interview. That could take 2 to 3 days. We set up the interview. From that point we request references. That can typically take another 3 to 5 days. Then you have to reach out to the references. So from that period, it can take 3 to 4 weeks. So it's not just that we sort of leave people in the wind, it's that you're getting a hold of people that are typically working full-time. They almost always hold a healthcare position somewhere else. They might be coming off night shifts. So we follow up. Sometimes it might take a week or 10 days to schedule that interview. So from our perspective, you're absolutely right. There's definite room for improvement, but considering all these factors, 4 weeks from the day they apply to when we extend a verbal offer, it seems like an improvement as far as our typical timeline goes. To your second question regarding the career fairs, one of the main things that we focus on when we attend these is to just provide information. Not all of the events we go to are considered career fairs. Some of them are healthcare conferences where job seeking is perhaps not the initial goal. It's more just we're learning about perinatal health, for example. So when we attend, we are definitely working with students or healthcare professionals to, work on branding, messaging, building relationships, perhaps with educational institutions like universities and things like that. So we measure the success of those events in a number of ways, and we collect information from them, and we do reach out periodically to assess interest, especially with people that may not have graduated. I've done that myself, where I've sent emails to people and said, I know you're graduating in the next 6 months. What's your level of interest in pursuing a career in the Northwest Territories?
Thank you very much. Next on my list, I have Emily Bonnet-Rouge.
Merci, Madam Chair, and merci for the presentation this evening on health recruitment. I don't know, healthcare, I guess, could have been the term, and healthcare relates to nurses and doctors, as there's many people in our aging population are getting older, and there's also an increase in serious ailments. That's including cancer. And you must know about all the problems that we have in our small communities. There's numerous cases out there in the newspapers, and I think I brought many to the floor of the House and to the department about the lack of training or proper equipment to do proper assessments to catch probably cancer at its early stages, or even the fact that if they don't know what, they haven't assessed a lot of the patients that go in. They just send them home with a Tylenol. It's been known for 4 years that I've been here, that I've been harping on this in the House and to the department. Nothing's been done. And then we throw in COVID, which really threw a wrench into the whole system, with nurses, moving on, going to taking other jobs. So that's where we're at with with healthcare for our small communities. And you showed me a graph there. I don't know what page it was on, but it's for the dead show for Fort Providence. You're throwing more social service workers at us. Is that because you can't provide us with nurses, that you're throwing social workers at us? I'm just wondering what is happening there. You could explain that to me, Mussy.
Thank you, Emily Bonnet-Rouge, Deputy Minister.
Thank you, Madam Chair. I would just maybe turn it over to Ms. Ross here to explain why those hires were made in those communities. Thank you.
Thank you, Deputy Minister. Ms. Ross.
Thank you, Madam Chair. Honourable Member, pardon me. I wanted to point out that since August 1st of 2020 to June 30th of 2023, we've actually hired 30 healthcare professionals in your region. 4 of which were most recently, just this past year, were the 4 community social workers. So there have been a number of hires in your region. I do understand, of course, your frustration, and I don't have the breakdown of what those 30 staff members are currently in front of me, but we can certainly get that for you.
Thank you very much, Ms. Ross. And I also just want to point out that the Department of Finance is in front of us, and so they would be hiring based on health's direction or identified needs. And I'll pass back to yourself, Emily Bonnet-Rouge.
Yeah, Mussy, well, obviously, I didn't get any answers. You know, why are they throwing social services workers at us? I think we got enough already. What we need is real nurses in our communities. Now, I'm just wondering if the department is even aware of, you know, how many nurses are at any given small community health center. You know, how many are actually required to staff the small community health centers. So I know there are problems there that I'm hearing, because all of a sudden when you're down to one nurse, then they're put on emergency mode and they won't see anybody or even talk to anybody. And that's getting quite concerning, because we don't even have any. Even that one nurse should be able to see people. So I'm wondering if the department even knows those statistics that I just mentioned. Mussy.
Thank you very much, Mr. Bonnet-Rouge. And right now we have finance in front of us who would be more poised to answer questions about the recruitment of healthcare workers. But next up, we do have Health and Social Services who will be coming up and providing a presentation on the deficit of NTHSSA, and they might be able to address your concerns through, I guess, a more of a deficit angle on that. But I don't know that I don't know that finance will have the information about the required ratio of nurses in a healthcare
They should have the
center.
stats.
I can definitely ask them if they have the stats, but I just want you to be wary that finance is in front of us in regards to recruitment and retention of healthcare workers. But I'll turn it over to the Deputy Minister, who can let us know what stats they have in front of them here. And then maybe another question from another angle when we talk about the deficit of NTHSSA might be helpful as well later to get health's perspective as well. I'll pass to yourself, Deputy Minister.
Thank you, Madam Chair. So as you mentioned, we do have the stats. I don't have them at hand here, but we can get back to the member on where, sorry, Colleen does have them. So I will turn it over to Colleen. She can outline some of those, the stats for the number of people in each community. As you mentioned, as for the resources that are required in each health center, we leave that to health to kind of determine what's necessary. We're basically they're our client in terms of recruiting staff for those health centers. I'd like to turn it over to Colleen, please.
Great, thank you. I take your point that staffing in small communities is a challenge. There's no question about it. We have a certain set of positions, and if deemed necessary by the authority, we absolutely post them and try to fill them. So we're filling all vacant positions that we have been given direction to fill. When I just pull up the recent statistics for the last fiscal year, I can see there was a nurse in charge in the DHO, a foster care and adoption worker, a nurse in charge for home care, community health nurse, mental health and addictions. We can provide these statistics in written form because I think it might be too tedious, but we are always filling a variety of positions. It's not a focus on one position to compensate for not filling another position. We're always searching to fill the positions that are currently vacant.
Thank you very much for that, and committee would definitely appreciate the data as well in written form. Emily Bonnet-Rouge, I know that both of your questions were in regards to data that committee has asked in a follow-up. Do you have an additional supplementary question that you would like to ask at this time? Okay, excellent. Thank you so much, Emily Bonnet Rouge. I'll now pass over to the phone lines to Emily Simpson.
Thank you, Madam Chair. And I guess a couple of questions here. And the first one is, and I'm hoping that I'm asking the right people here, is that the federal government, provided additional money that we for healthcare that we find that it's insufficient. And so I'd like to know, what is the department, doing, between finance and health to negotiate, a package, funding package that will address the deficits that we are facing, because these deficits are impacting, access to timely and quality health care to residents of the Northwest Territories, and it's been going on for some time. And if we don't have the staff, we just can't provide that, and it's adding to the overall cost, I suspect, of providing that health care when we got to start sending people to Southern Canada to access it. So I guess my big concern is it seems like money is the issue from when I read through the material, and I'm just wondering, what are we doing as a government to ensure that the federal government is coming up with adequate funding so we can adequately deal with the health care issues that we're having in this territory? Thank you.
Thank you, Emily Simpson. Deputy Minister.
Thank you, Madam Chair, and thank the member for the question. Well, we do engage with the federal government pretty regularly on all types of funding, including health funding. So some of the areas that we had been focused on was Canada Health Transfer, which was increased by the federal government for all provinces and territories, including ours. So that's another $10 million that we'll be getting per year for health care funding. And the Department of Health, and they'll be coming after me, can probably give the member a little more details on this, but the Department of Health is engaged with the federal government on ensuring that the NIHB program is well funded, so that's a big portion of our medical travel, so ensuring that that's well funded so we covers the cost of medical travel for us on that, in that regard. And then, as I think we've mentioned a few times at this table, the TFF is the main source of healthcare funding and all funding for the government, and that's something we're engaged with the federal government on regularly in terms of ensuring that reflects the true cost of delivering services in the territory. Thank you.
Thank you, Deputy Minister. Emily Simpson, do you have a follow-up question?
Yes, I do. Thank you, Madam Chair, and I thank the Deputy Minister for that response as well. Over the last, probably 4 years that I've been here, what I see is that, we talk about the economy and we talk about, growing the NWT, and to do that, we need a healthy population, both, health-wise and mental health as well. And it's so important that we strive, I guess, to make sure that we provide that timely health care with and quality health care with professionals that we need. And I know that we have the Hay River Health and Social Services Authority, which is separate from the GNWT or from the NTHSSA. Yet when we I hear that when we're in negotiations here, we're talking about negotiating for 2 years that have already gone by after the fact, and I think it's kind of demoralizing for some of the staff. So and some of the things when I'm talking to people there is what is it that that's an issue, and one of the things that come up is, and I guess as it does in anything, is money. So I guess I'd ask the Deputy Minister, what is the perspective of the department when it comes to the difference between us being comparable to the South versus actually being competitive? Because in years past, the territories was always a place where people could come, they can make a lot more money, and when they decide to go back to where they're from, they were not only probably more training, but also were well compensated for it. And we don't have that anymore. And that's one of the things I hear constantly is that, and that, especially after COVID as well, people do want to be closer to home. They want to be closer to family. So somehow we have to make it so that people actually want to come here and work and provide the services that our residents need. So I guess again, what is the difference that the department sees when between comparable versus competitive? Thank you.
Thank you, Emily Simpson, Deputy Minister.
Thank you, Madam Chair. I take the member's point, and it's a good one, that we do have fairly high salaries, but in the last few years, we've been less competitive, as he noted, in terms of the salaries and the bang for the buck, as Ms. Welborn mentioned, that people might get from those salaries. But we have done. We still have the second highest, at least for registered nurses, second highest average salary in the country for that class of employee. We also, as we mentioned in the presentation, have put in a labor market supplement for specific healthcare workers, so that's increased the pay that they get even more. And then, as the member mentioned, we're in the middle of collective agreement negotiations with both the NTHSSA as well as the GNWT, and those will result in renewed collective agreements and renewed benefits package for healthcare workers and for workers in the rest of the GNWT. So working very diligently on ensuring that we remain competitive as an employer. Thank you.
Thank you very much. Deputy Minister, Emily Knockleby.
Thank you, Madam Chair. My next question is really quite a short one. Why isn't Hay River part of the HRU or the Hay River Health Authority? Thank you, Madam Chair.
Thank you, Emily Knockleby. Deputy Minister.
Thank you, Madam Chair. So that's a historical anomaly. I don't know the full background to it, but they amalgamated the authorities, and Hay River stayed outside of that amalgamated authority. I don't know if Ms. Welborn, if you have any more details on that.
The history, no.
Okay, but I can undertake to get back with a better answer to committee on that.
Very much, Deputy Minister. Emily Knockleby, do you have a follow-up question?
Yeah, thank you. I guess just without knowing the history of why they decided to stay out, I don't understand, or I guess maybe you can explain to me why we still wouldn't have the HRU help the Hay River Health Authority also hire, if they're doing global competitions for nurses all throughout the Northwest Territories except Hay River. It seems like it would be, as considering you're the Department of Finance and HR, and you would have some sort of a piece, I'm sure, of how the hiring is going in Hay River as well. I'm not sure why this unit wouldn't then spread and cover all hiring in the Northwest Territories. So I don't know if that gives you more to answer back, or if you want to come back with more of a written response. I'm okay with that too. Thank you.
Thank you, Emily Knockleby. Deputy Minister.
Yeah, thank you, Madam Chair. I can get back to the member on that particular question as well, but I would say, I guess, which I think she noted herself, it's a separate institute. It's a separate institution from the GNWT. So HRU's client departments are GNWT departments. So that's one of the main reasons. But again, I'll get back with a more detailed answer on that. Thank you.
Thank you very much, Deputy Minister. Do you have a short follow-up, Emily Knockleby?
I just always struggle when it comes to us in our role and these sort of arm's length and third-party entities, because, you know, we are authorizing money and we are making all these other decisions that affect these authorities, but then it really seems like there's these weird sort of disconnects where there's a duplication of effort, duplication of staffing, all of this, and I'm obviously probably talking about a much larger issue that predates this assembly, and probably nobody really has a great answer for how it's evolved this way. But I guess I just want to make a comment that I hope it devolves out of this to where we are actually looking at efficiencies, because one of the comments that's made to me is that once HR came out of Health and Social Services to the Department of Finance, that's when it started to slow down. And whether that's a true statement or not, that is a perception that is there within healthcare workers themselves, and that is where it is being sort of blamed at times for the lack of progress with making offers and things. And so maybe that's just more of a comment than a question, but a perception that's out there. So thank you.
Thank you, Emily Knockleby. Deputy Minister.
Thank you, Madam Chair. I've heard those same comments as well, that when it was centralized, it slowed down the process. But that's, as we mentioned in our presentation, that's something we're aware of and are working on to ensure it's as efficient as possible. Thank you.
Thank you, Deputy Minister. Next, I have Emily Simpson.
Thank you, Madam Chair. I guess a question I have is that we're talking about job fairs and that. I guess what I'd like to know is when they are talking to prospective, I guess, employees, anybody that might want to come and work up north, what is the feedback, I guess? What type of questions are we getting from these prospective employees? Is it like is it about money? Is it about lifestyle? Is it about cost of living? Because I just kind of want to get a feel for, what might be stopping people from wanting to come north. Thank you.
Thank you, Emily Simpson. Deputy Minister.
Thank you, Madam Chair. I might turn that over to Ms. Wellborn. And again, as I mentioned before, she's in the trenches on these, so we'd have a better idea of that.
Or source.
Great, thank you for the question. I think a lot of what we hear from people, we talk to a variety. So there are students, some of them are still in school, finishing their studies. A lot of them are very interested in pursuing the adventure, pursuing the financial remuneration, as well as the student loan piece. We try to really push that a lot of those are remissible if you come north, the federal student loan as well as breaks here. What we hear from students a lot of the time is just the fear of the unknown. For a lot of people, as we all know, some people don't know the difference between Whitehorse, Iqaluit, Yellowknife. So we do a lot of education on that and how we're different and what we have to offer, how we're connected, how we are a city with services and chain restaurants and things like that to sort of alleviate their fears, especially new graduates. So we really focus on that. For more established job applicants, we try to sort of meet them where they are. If they're people with a family, we talk about how it's a great place to live and raise a family. We have great education and health services. Your commute to work in small communities is virtually nothing. Even in Yellowknife and Hay River and Fort Smith, it's very small. So we try to really cater our marketing conversations to people if they like the outdoors and lake life. So it's kind of the thing that we're allowed to do as a strategic unit is to be strategic and sort of address groups of individuals a little bit more individually. As I say, though, a lot of the feedback is people think they're interested, but then when they really are faced with the prospect of moving their entire life across the country to the unknown, they often have second thoughts. Or conversely, we're dealing with healthcare professionals who have a great interest in serving their fellow human and their community members. And so when they think about giving notice at their current job, they often get second thoughts because they're leaving their current employer in a poor place and they have a duty. They feel they have a duty. So it's a challenge. It's a challenge for healthcare people to pick up and move. I think it's a challenge for everybody, but that's the feedback that we've received. Thank you.
Thank you very much, Ms. Wellborn. Emily Simpson.
Thank you, and I think thank you for the response as well. But the other thing I guess as well is with respect to the Hay River Health Authority, is that in these negotiations that are going on right now, I hear the CEO put something out and say, well, we can't offer any more than a GNWT. So when I hear that, and I know we're a separate entity, I start thinking to myself, well, if that's the way it's going, we probably should look at possibly, at amalgamating with the NTHSSA, if that's the case. So I guess I'd like to kind of know is, how much control, I guess, does the finance and I guess finance have over the Hay River Health Authority when it comes into negotiations, because they seem to be, if they're looking after the purse strings and they're not at the table really, they seem to still be controlling it. So it's still government controlling it, and I kind of have a problem with that because for me, when it comes to healthcare, that's all a person really has. When it comes to life, is that your health, and it's important that we make sure we we provide remuneration to the healthcare workers, the type of remuneration they really deserve. And if we have to increase that amount, I think we have to find that. And that's why I guess before I alluded to, the federal government and trying to find additional funds to make sure that we have the people we need here. And one of the things that seems to be a big holdup is this pension fund aspect of it, and nobody seems to really know what that number is to bring the Hay River Health Authority into the NTHSSA, and that's a number I'd like the department or deputy minister to find out for me as well. Thank you.
Thank you, Emily. Simpson, Deputy Minister.
Thank you, Madam Chair. So just to start with the last question there, we can get back to you again on what would be required for the authorities to come, for the NTHSSA to merge with the HRHSSA, but the member is right, it is a matter of the pension, having to buy out the pension from those or convert that pension to GNWT benefits. As far as, just to give the members a bit of a flavor of how the collective bargaining process is approached by the Hay River Health Authority. They are a separate authority. Their employees are not public servants of the GNWT. They're governed by a different collective agreement, so they go and negotiate separately with the UNW for those employees and those members of the UNW. And the mandate is given by FMB as to giving them parameters around that they can work within during those negotiations. So that's the involvement of finance, but otherwise the negotiations are all conducted by the authority. Thank you.
Much, Deputy Minister. Members, are there any additional questions in regards to recruitment? Hearing none, I have a couple of questions, if I may. Watching the presentation and hearing the hard work that's being done by finance to recruit healthcare professionals, I can't help sometimes but envision it as a bit of a sieve. You're trying to fill a bucket of water, but the bucket has a lot of holes in it. And what I hear from a lot of the healthcare professionals who are the people who I serve are that their concerns within their current employment structure or employment setting are not being addressed and are not being heard. They have been asked multiple times about, what's not working well, but they're not seeing the change at the front line or on the ground. And at the end of the day, some have referred to it as death by 1,000 cuts, and then they walk away. And, there was the reference to transfer to non-kind of frontline roles. And it's been very obvious over the last 4 years of a lot of people going from frontline positions to work in headquarters or work in health and social services. And so I'm wondering if there was mention of the HRU having a seat at the table with NTHSSA and Health and Social Services. And I'm wondering if there is opportunity for HRU to either conduct exit interviews or be involved in that work, or to kind of hold NTHSSA accountable to some of the items and issues that are really driving some healthcare workers out of frontline work. Thank you. Deputy Minister.
Thank you, Madam Chair. So, yeah, there were very public calls from nurses and other health professionals for for the government to look at some of the issues within the healthcare system and the government generally in terms of retention. So a lot of work has been done in response to that, and I might get Ms. Ross to give us a bit of a summary of what they've been doing to address those concerns. Thank you.
Thank you.
Thank you, Thank you, Deputy Minister McKay. Madam Chair, thank you for your question. I can tell you that we do sit at a number of tables with NTHSSA and the TCSA with respect to not only health recruitment, but obviously in providing advice to them from an HR perspective on a number of their matters. We have a different set of committees that the client service teams all participate in. I've sat myself with some of the senior leadership as well to talk about a number of the issues. And I can tell you that HSS and NTHSSA have been working on, those recommendations that came forward as a result of the nursing survey and putting some of those practices into place. Just actually today received a bit of a briefing that I haven't had opportunity to look at yet in terms of some of those items. But we certainly work with them to ensure that employees are happy. We want our employees to be happy. We want our employees to stay working with us, obviously. In terms of exit interviews, this has come up a couple of times now, and we've been discussing this internally in HR with respect to the whole of government, not just healthcare professionals, and working on a plan to bring back exit interviews. And to put a process in place to ensure that that's something that we move forward with. So it's currently under review, and I anticipate that we will be seeing the results of that review in short order and likely something that we'll be moving forward with.
Thank you very much, and I appreciate that. I think understanding what's causing, I guess, the holes in the bucket is crucial to being able to support the work that you're all doing so that you're not just constantly throwing, more water in to have your work being washed away. My next question is I've got many, but there's currently healthcare workers that are living in our community who are not working in frontline capacities for a multitude of reasons. I've had as an MLA represented a few different constituents who have had to work substantially hard to get contracts in hand to be able to turn around and do the work, all while being recruited by other jurisdictions. And, I will say they were working with their direct supervisor in a casual position, but it was a very difficult process. There are other people who are retired frontline healthcare workers who are literally down the street from the hospital while people are being brought in by locums. And there are also retired people who have worked for the GNWT for 30 years and have said, I'll come work as relief. And we're told, well, we'll set you up with a job interview. And they kind of said, well, if my 30 years isn't good enough, maybe I won't be successful in an interview then. And so are there mechanisms that, and that being said, there's also people who are living in the territory who are waiting on kind of the support necessary to go through a foreign licensing, the challenges associated with that. And so I'm wondering if there's work being done with NTHSSA to identify who these individuals are and the barriers that are present, whether it is people who are retired, whether it is people who are really just having a struggle to kind of get through the system because maybe they're at the wrong door, maybe the door they're trying isn't working. And so, and then people who kind of need that support to get Canadian licensing. So I know there's kind of multiple pieces that I'm pointing at there, but they are all qualified individuals living in our communities who are not being used to the best of their abilities. Deputy Minister?
Yeah, thank you, Madam Chair. We've heard about that challenge as well, the people that are qualified for these positions but not able and willing to work in them but not able to get into place. So, but I maybe could turn it over to Ms. Welburn to maybe talk about specific things that the department's doing to address that. Thank you.
Mr. and Ms. Welburn?
Great. Thank you. All right, thank you. Just on your first piece about facilitating expedient hires, especially for locals, we take the approach in HRU that anyone who is an accredited healthcare professional, we want to find them a job. Sometimes they're qualified to do a job that's filled. It might be a niche, specific type of job. We look to see if there are any ways that we can fill those. We look to see what skills we can perhaps build upon if they need to develop in terms of, is it a developmental transfer assignment? We can facilitate advice on that. Like I say, we take the approach that if anyone is wanting to work, we will do our utmost to find them a suitable fit.
I can't speak to any specifics. I don't know of people that have been knocking on doors and aren't getting an answer, but we do have a variety of ways to get in touch in terms of, you know, my contact information, but we also have a HLTHSS_recruitment inbox, and that's a mechanism that people from around the country get in touch with us, for people that are looking for casual work from anywhere. But we also use that inbox to hire people indeterminately as well as people who speak to healthcare managers. Obviously, they are, you know, constantly overworked, but we work with managers on a very regular basis. We have regular meetings. We speak with them all the time about how we can support them. And if there are people, they know their staffs very well typically, so they're able to say, you know, this person, I don't have a place for them here. Is there a place we can look to there? So we try very hard to work with our team members and managers in those roles. Like I say, we are still open for you know, more feedback, and if people are looking to get in touch with us, they absolutely can. I pride myself on taking any call that anyone makes. If people call HR looking for someone in health recruitment, it will almost always get directed to me. So that's something that I can commit to doing. As far as the international piece, you know, we work with a variety of partners. It's not just the government. We also work with the credentialing body, the Registered Nurse Association for NWT and Nunavut. They have their own requirements for credentialing foreign nurses. So I meet with them personally. I know they meet with other people in health very regularly. Being that we are a remote jurisdiction with a different set of challenges, I believe there are very, you know, reasonable reasons for pursuing international accreditation carefully, and so I believe that they are taking a lot of that feedback and considering it, but at the end of the day, those are decisions that are not necessarily the Department of Finance or even the Department of Health, but it is something that I know is discussed on a territorial level as well as a national level. Thank you.
Thank you so much, Ms. Welburn. Members, are there any additional questions? Hearing none, let's take a few minutes just to switch out our witnesses, and thank you so much for your time this evening, and we will be back with the Health and Social Services System Sustainability Briefing in just a few minutes here. Thank you so much. Thank you very much for joining us this evening. We now have in front of us Minister Julie Green, joined by the Department of Health and Social Services, in regards to a political briefing on the Health and Social Services system sustainability. And so with that, I would like to pass directly to yourself, Minister. If you could please start off by introducing your guests with you this evening for the record, and then proceeding with your opening remarks. Thank you.
Thank you very much, Madam Chair. Sitting next to me is Jerry Cheesy. He's the chair of the NTHSSA Leadership Council. Next to him is Tim Van Overloo, Acting Chief Executive Officer of NTHSSA. And on my right is Deputy Minister Joanne Chiquetto. Sitting behind me is Jeannie Matheson, Assistant Deputy Minister of Finance Policy and Planning. Marissa Martin, Chief Financial Officer for NTHSSA. Kate Sills, Senior Advisor to Joanne, and Liz King, my Special Advisor. Thank you for providing me with the opportunity to provide an update on work related to the financial sustainability of the health and social services system. Madam Chair, we understand that the issues of financial sustainability and the deficit within the health and social services system are of significant concern to all members of the Assembly. We're committed to implementing the sustainability plan and making necessary changes to ensure the continued availability of high-quality services for the residents of this territory. And I know that Mr. Cheesy is on the same page with this commitment as well. Fiscal sustainability challenges in healthcare are not unique to the NWT. All Canadian jurisdictions face financial pressures in delivering services. Despite significant additional funding from the federal and territorial governments, delivery of current services and programs continue to add to a significant deficit. The growth is based on a number of factors. One is that we are remote. Another is that as a result of that, we rely on southern jurisdictions for enhanced services, and this is a costly thing. We also face challenges related to the national shortages of health professionals, along with a significant rate of inflation. We are also facing new and competing factors that hinder progress in advancing and achieving system sustainability. Examples include increased costs of freight and materials, rising costs that impact on medical travel and the movement of health professionals, and frequent requests and requirements for new or enhanced programs and services, often without additional new resources. To address these challenges, we're open to making significant changes to improve the financial position of the health and social services system. The HSS System Sustainability Steering Committee, established in 2021, has been guiding research and decision-making in this critical work. The steering committee is comprised of senior leadership from the Department of Finance, the Department of Health and Social Services, the 3 health and social services authorities. The NWT-HSSA leads this work, and I assure you significant progress has been made. I'd now like to invite Jerry Cheesy, the Leadership Council Chair, to provide additional opening remarks. Thank you, Madam Chair.
Thank you very much, Minister. Chair Cheesy.
Hi, good evening. Really happy to be here as chair of the Leadership Council. My colleagues and I have take this work as our role seriously, and we really want to do everything that we can to help improve the quality of care in the NWT for our residents. So I'm happy to be here this evening with the Minister to speak to this sustainability plan. We're tasked with overseeing the work of the NTHSSA. We provide advice and service to the Chief Executive Officer and as stewards of the Financial Operations Authority. The Council has overseen and supported the development and implementation of the sustainability plan since it was proposed in 2020. In the past year, the Council has developed a draft strategic plan that contains a strong focused on financial accountability and sustainability. Significant improvements have been made to our financial operations over the past 18 months, which has received recognition from the Office of the Auditor General of Canada. This and other work has positioned the authority to better understand the cost drivers of the current deficit situation we face. And this next statement is key. The magnitude of the deficit is such that it is not solely within the ability of the authority to resolve. It will require the support of the GNWD partners to assess historic underfunding alongside increasing demand for expanded programs and services. This next statement is also very important. While we highlight that ensuring the services we provide now and in the future are appropriately funded, we also recognize there are always areas where efficiencies and savings can be found within our operations. Today you will hear about some of our efforts to find savings within our current operations, and this work will continue as part of our sustainability efforts. As part of the next phase of work towards a more sustainable system, the Leadership Council has recently proposed to the Minister that a deficit reduction plan become a key part of the broader sustainability plan over the next several years. Having said this, we believe that the work of the sustainability plan and the focused deficit reduction plan presents a pathway towards reducing the deficit trend of the past several years with associated resources, support, and collaboration that will be required to ensure success. Also, this and other work has positioned the authority to better understand the cost drivers of the current deficit situation we face. It is important as Chair of the Leadership Council that I share with you that the Chief Executive Officer and her executive team have the full support and confidence of the Council to lead the organization on this continued path to improvement. At this time, I would like to turn it over to NTHSSA Executive Director of Corporate and Support Services and Acting CEO Tim Vanderloo to lead the presentation. Thank you.
Thank you very much, Chair Cheesy. Mr. Van Overloo?
Chair, thank you, Mr. Cheesy, and thank you, Minister Green, for those opening comments. Kim Riles, CEO of the NTHSSA, who was scheduled to present, is unexpectedly away dealing with a medical emergency with her son. And so she does send her regrets and apologizes for not being available and really did want to be available for this presentation. But as Acting CEO and ED of Corporate Support Services, it's my pleasure to provide the committee with an update around some of the activities around the sustainability plan. And happy to go through it with you and answer any questions as we go through. So on the next slide, there's a little bit of an update agenda of what we'll talk about. It's really framed in three areas. We'll talk a little bit about the background and the structure of the sustainability plan. We'll have a high-level overview of some of the work that's done to date, so you can have an idea of the scope and magnitude of some of the work that's occurred. And we'll talk a little bit about the financial position of the NTHSSA and some of the next steps moving forward. And throughout the presentation, even from the branding of the presentation, you'll see it has a focus on the NTHSSA, but as you heard earlier, sustainability within the NWT Health and Social Services system is a collaborative approach with our partners, both the other two authorities, the Department of Health and Social Services, and our partners through the GNWT and the Department of Finance as well too. On the next slide is a little bit of a background for the committee around how we got here today. Sustainability or cost savings within the health system is not a new initiative. It's been ongoing for several years. So the sustainability plan and some of the detail that we're about to share with you here today is the next iteration of that work. In short, it was largely driven by the escalating deficit of the NTHSSA, who carries majority of the deficit of the health system. And it was really focused on putting measures in place to to contain the increasing cost of the deficit, as opposed to eliminating even historical accrued deficit or any of the current deficit from prior to amalgamation. And really to expedite the planning and the support for these activities, we leverage funding through our federal partners, through the government through the Territorial Health Investment Fund, and put together a small team which we embedded under the NTHSSA, primarily because a lot of the activities focused on cost containment, which are the early drivers of our sustainability plan, which I'll speak to, were primarily driven within the authority, as well as we learn from the support of these individuals to help navigate and move initiatives forward. We're having the ability to integrate them into standing business within the authority as well too, and so we can learn from the individuals that help support the sustainability work in the long run. And again, as you heard earlier, a lot of this work is grounded by a steering committee and guided by a steering committee made up of deputy head level representatives from the Department of Finance, Health and Social Services, as well as the NTHSSA, with key support from the other two authorities and staff. The next slide gives a high-level overview of the sustainability plan, and it's really framed in 3 tiers. And the tiers is a really important concept for us in this planning, because as you progress through the different elements and tiers, the complexity of understanding and preparing and proposing initiatives for cost reduction or deficit reduction becomes more complex, as well as the potential for impact also increases as well too as you go through the tiers. So the first tier, which is a lot of the updates I'll share here today as well too, are really focused on controlling costs and having some cost containment. And so those are founded on having better understanding of our operations as an authority, how we intersect with our key funding partners, and how we are managing some of the day-to-day activities so that we can make better business decisions and clinical decisions related to how we're spending money and delivering care for clients across the NWT. The second tier is really focused around quality and quality improvement. So the NTHSSA, since amalgamation, has been on a quality journey, initially focusing on ensuring that we have quality assurance so we can learn from incidents that are occurring across the organization, both from patients, clients, as well as our staff. And we've just recently turned that focus towards client experience and understanding from our patients and clients around their experience so we can then adapt and change. And part of the sustainability work is providing the quality improvement initiatives in frontline individuals' hands so that they can actually see changes with a focus on efficiency and effectiveness and make them in real time. And so we'll talk a little bit about some of the key initiatives that have initiated over the last little while related to that. And then, as important, since we've been an organization since 2016, we have an opportunity now to really look at our management structure, our organizational structure, and some of our non-clinical functions to see how we've organized ourselves and if there's opportunities not only for efficiencies, but understanding our comparisons against other jurisdictions. And so you'll hear later on in the presentation some detail around external consultants that have been partnered for us as we move forward. And then the last tier is related to funding and service level reforms. And the focus here is understanding what is core business for the authorities and trying to ensure that we are realizing the cost of efficiencies and realizing the revenue generating from different sources of income for us as an authority. And so again, as I mentioned before, the complexity of these discussions, decisions increases as you move through these tiers. The next several slides will provide a little bit of a high-level update related to some of the activities that have occurred across the organization and in support from the other stakeholders within the system. This slide really frames up some of the processes, plans, tools, and reports that have both allowed us to both monitor our expenses, but also help us to improve our processes to mitigate some of our costs. And so you'll see in here there are significant changes in the way that we monitor and report on overtime internally so that we're giving the tools to management as well as senior leaders to make decisions in real time around how they're managing their staffing models and schedules. We've also been able to improve some processes around billing and receivables so that we're actually getting billing out to different stakeholders in a timely fashion. And that's
reducing our bad debts throughout the organization. And there's been quite a significant work around procurement processes and service contracts, so amalgamating contracts, looking at contracts so that we can get realized benefits with different vendors. And again, these are improvements that are being made at the program level, and so we'll see, as an example, we've had some success with our biomed work where we're looking at the multiple vendors that we have and amalgamating those contracts and having some cost savings related to those areas as well. The next slide is really focused around some of the fundamental improvements we've done across the organization. Again, these are all focused around cost containment initiatives and cost controls for our ability to forecast and influence some of the key drivers of our deficit drivers. So again, you'll see here there are several areas around the way that we're budgeting, the way that we're forecasting, so we can provide better information to our leadership team as well as to managers, so we can manage areas of improvement and where we can focus some cost savings activities, and giving us an ability eventually to actually start to benchmark. We've made some real specific, tangible cost controls related to visa usages and how we're managing some of our procurement and expenditures. And then, as you heard earlier today, excuse me, physician management is a key driver for us because of the cost of compensation benefits across the organization. And so some of the improvements that we've made in collaboration with our hiring team, HRU, as well as Department of Finance, has given us an ability to really improve the timelines for people to get into positions that are vacant. Some of the next slide is really focused around that tier 2. So again, this is getting into more of the quality function of the organization, and just online, I think it's a slide back, if you don't mind. To slide 7. Perfect, thank you. A lot of the tier 2 actions are grounded and around a focus of quality, as I mentioned before. And some of the key activities here are, we thought at the beginning of the sustainability plan that we could really leverage benchmarking against other organizations. And early on in the work, we realized that there's a significant amount of data improvement we had to do to ensure that we can start to benchmark ourselves, not only internally, but also against other jurisdictions. And so the primary focus over the last several years has really been focused on allowing ourselves to get that right data into the right stakeholders' hands so that eventually we can start to compare ourselves to other jurisdictions. I mentioned that there was an external consultant to conduct both an operational review as well as some business process reviews. And you heard some of that update on the earlier presentation around our relationship with our shared service providers. And most of that is focused around how can we improve the efficiencies and the timeliness of service between the two organizations. And a lot of the feedback there we're waiting for from our consultants to be expected soon is related to, again, those cost comparisons to other jurisdictions around some of the similar non-clinical functions that happen across other authorities across Canada as well. And really trying to benchmark ourselves against those, but also to get a sense of how we can improve or be more efficient from where we thought we would be in 2016 when we amalgamated. And then lastly, around some of the quality improvement, as you can see there, we've had a significant amount of staff have been trained on a specific quality improvement model, and that quality improvement model is giving tangible tools and ability for frontline staff to eventually start to work on quality improvement initiatives. And again, putting the responsibility as well as the accountability and the initiative in their hands to, if they see an opportunity for improvement, they can start to work towards that. And so we are in the initial stages of rolling that out a little bit more broadly across the organization and actually starting to pilot now that some of the trainings occurred. The next couple slides are really focused around the tier 3. So these are programs and initiatives that are primarily partnered with the Department of Health and Social Services and really focused around looking at a large-scale funding opportunities as well as processes and changes to the way that we deliver services. So 2 of those initiatives are focused around referral coordination. As we know, the amount of travel, the amount of patient movement that has to happen in our jurisdiction, both internally across the NWT, but also external to the NWT. It comes not only with challenges from patient care, but it comes with challenges related to costs as well too. And so there are a couple opportunities that we're focused on to improve the efficiency of that process. So ensuring that people don't have to travel multiple times for multiple services, ensuring that we're bringing care and services into the community so we can get care closer to home. And again, these are in the early stages of scoping, so we can understand both the financial scope of these initiatives, but also the scope of improvement that might have to happen. And from a consideration of uninsured services, as I mentioned before, some of the key priorities under this tier is looking at where are the core services for the health system and how are we being funded for those services. And so there are examples where historically we've delivered services for various areas, and now that we have better financial management, we're starting to understand where there might be gaps in funding or gaps in the ability to effectively deliver that service with some of the historical funding that's coming from those areas. And so over time, we'll start to explore those and bring those through the normal channels with our partners in the Department of Health and Social Services. And then the last 2 Tier 3 funding and service level reforms are really, you heard some of it earlier today related to the non-insured health benefits and some of the approach that we're taking both with our partners across the GNWT back to the federal government and Indigenous Services Canada. And so there has been a commitment by the GNWT to work with Indigenous Service Canada to look at that agreement so that we are not continuing to deliver programs that are not at a full recovery cost. And primarily the big cost centers for those are related to medical travel. So our government provides quite a bit of financial support as we administer the medical travel policy for individuals that are beneficiaries of NIHB. And so there's a significant opportunity there through those negotiations to look at cost savings for, or additional revenue for the GNWT and for the health system as a whole. And then again, another example of this is some of the pan-Canadian alliances that have been started specifically to pharmaceutical, where we've been able to negotiate drug plan between a drug plan and drug manufacturers to get reimbursements for several of the drugs that we purchase through those plans. And you can see there that they're not insignificant numbers when we're looking at these plans, and we've had the ability over the last 2 years to be successful in moving forward and reaping some of those benefits related to those agreements. So with that said, the next slide on slide 10 really focuses on where are we now. So as I mentioned before, at the amalgamation of the NTHSSA in 2016, it was amalgamated with accumulated deficit to start, and the driver of a lot of this sustainability work has really occurred leading up to 2020 when there was starting to be significant increases in the deficit of the organization. There are several drivers of that deficit that have been shared both in our annual reporting through the authority, but also through the business plan, through the Department of Health and Social Services. And part of the work of the sustainability plan is really focusing on those opportunities in areas where we can reap not only quick wins related to cost containment, but also an opportunity to explore where there are major changes that can happen that can actually help contain some of that deficit. And the urgency of it and the thankfulness of the committee to allow us to present some of these details and answer some questions is the fact that for last fiscal year, we're also trending that this deficit trend is expected to increase. And that's partly for a lot of major factors, but primarily, as we've seen across Canada, there's been a real health and human resource crisis. And as you know, not having a stable and representative workforce in the NWT, we can't stop operations, where a lot of our operations are 24/7. And so in that case, we end up having to have more of a transient workforce. And with a transient workforce, as well as vacancies, as you heard from last presentation, it costs more for the system. And so really our focus is twofold, not only looking at these process improvements, but also looking at employee engagement and working on supporting our employees to feel engaged and to also advocate for them in what they want from their workplace. And what we've been hearing a lot, as you heard earlier today, is they want flexibility. They want the ability to feel like they have mastery and ownership in their work. And with some of the largest challenges we have is there's external drivers that are taking that away from them. So COVID is a perfect example where a lot of our employees have lost their accountability within their work because they were tasked with doing stuff way outside of what the normal operations have been. And I think largely what we've heard from staff is they want to feel supported and they want to feel like they can learn and develop within the organization. And so we've started not only listening quite a bit over the last 2 years, but now actively, as you heard earlier, we're on the tipping point of actually starting going back out to staff with what we've heard and getting their perspective on if these changes will meet that need. And so we're really excited about trying to fill that employee engagement stream alongside a lot of the sustainability work too, because if you look at the bottom line of our operations, about 48 to 50% of our operations is dedicated compensation and benefits. And so we really have to have a focus on our employees as we move forward. And then, as I mentioned before, a lot of the cost containment and the cost controls that we put in place has allowed us to actually represent our financial picture better and represent where there's opportunities for funding where are really uncontrollable to us. And that's where you'll see that last year from our supplementary funding, we've been able to advocate with the support of the Department of Health and Social Services for over $20 million in additional one-time funding. And this is a direct reflection of us understanding the business better, but also it's a direct reflection of there are a lot of uncontrollable costs that are happening to health systems. There's a rising supplies cost. There are rising costs across the board, even for some of the drug plans that we have and for many other areas. And so, again, this is not only a benefit as we've been able to secure some of this funding, but it also is showing that the trend is continuing to increase and shows the urgency for us to work collaboratively as one system to address some of these areas. And so where do we really go from here? So the sustainability plan was primarily driven as a collaborative initiative across government, across the health system, supported by the Department of Finance to really understand the different categories of opportunity for not controlling some of the escalating deficit that has been driving through the organization, but also through the system as a whole. Where we are at now is there's an opportunity for the NTHSSA as being one of the bigger players within that stakeholder group of the system, actually to have a very tangible deficit reduction plan to focus on controlling that deficit that's primarily under the umbrella of the NTHSSA. And so there are, as requested and as supported through the organization, we've developed a deficit reduction plan to align with the sustainability work, and happy to start to work towards that over the next several years related to the support from the Leadership Council as well as the support from the department as well too. And again, all of this is working to have some accountability for some of these results, as well as to make sure that they're appropriate and timely considering the urgency that I've expressed before. So I want to thank everyone for the time here today and turn it back over to the chair. Thank you.
Thank you very much, Mr. Van Overloo. First up on my list for questions, I have Emily Simpson.
Thank you, Madam Chair, and thank you for the presentation as well. I guess when it comes to healthcare, everybody's everybody's concerned in the Northwest Territories. It's not just one community that's impacted, and when we talk about healthcare, we talk about timely and quality services, and that requires staff and facilities. So I guess I'd like to know what impact will the deficit reduction plan have on services? Because we cannot look at diminishing or eroding services any further than they already are. So what is it? I guess that deficit reduction plan, what will the impact be on services? Thank you.
Thank you, Emily Simpson. Minister?
I'll ask Mr. Van Overloo, or did you want to answer that, Terry?
No, I'd rather not. Tim?
Okay,
Van Overloo?
Chair. And thank you for that question. I think this is a large question that we've contemplated amongst all this planning around trying to understand better where those deficit drivers are. And the reality is the cost of delivering care today compared to 5 years ago has increased quite dramatically for some of the reasons I just shared. And so as an organization, we've had to explore opportunities for understanding better where we're delivering those services and what services are delivered. And we're starting to bring those questions back up to our partners, the Department of Health and Social Services, around where there are opportunities to work with the public, but also work with our staff and our colleagues around, are these the core services? So it's never in our intent to reduce services. So the two approaches that we want to take here, one, are we being efficient in the way that we're delivering services today? And as I mentioned before, the efficiency for us primarily is ensuring that we have a stable workforce, because the transient workforce that we have to keep operations going is costly. So example, if you have a vacancy and we need to cover that shift, we typically start by covering that with relief. If that's not available, we'll cover that with overtime. Those are two very costly needs. And so ways that we can approach looking at our current services to make them more efficient is looking at scheduling. It's looking at, can we have information that we've been developing where instead of spending X amount of dollars on overtime, can we put another employee in and make advocate for that if we know that we can recruit those types of employees? So it's not a simple answer, and it's actually a complex question that I think several jurisdictions and authorities are looking at. But for us, it's primarily, one, understanding, are these the services that we are mandated and need to be delivered? And then within those services, are we being as efficient as possible? Thank you.
Thank you, Mr. Van Overloo. MLA Simpson?
Thank you, Madam Chair, and I think I appreciate the response as well. You know, I'm pleased to hear that the department is, putting the effort in, and they recognize that issues, exist with the delivery of healthcare in the territories, and they're trying to work to address them as well. But one thing I noticed is that, we continue to reference the challenges, and we always say, oh, well, they experience the same thing in the South, and I realize that. So I guess what are we willing to do, or what are we looking to do, if anything, at all, to set ourselves apart from Southern Canada, because we know, like the minister had mentioned there, we have increasing costs, whether it's freight, material, wages, everything. Cost of living is high in the territories, and the other problem is housing and those type of things. So we've got a lot of challenges here. And, we need the federal government to step up as well to recognize that and support it. But I'd just like to know from the department is, what are we doing to again, put ourselves, a step above what's happening in Southern Canada? Thank you.
Thank you, MLA Simpson. Minister?
yeah, thanks. I'll have a crack at that. And so I think that what we heard from the Human Resources Unit is really a lot of it is in the recruitment and retention, helping people to understand what they are going to experience when they get here. And to underline Tim's point, that we're recruiting people who want to be here. They understand they're being paid the second best wage in Canada to live in this wonderful place, and that the stability of the workforce is the thing that will, I hope, in the end, set us apart in terms of spending, because we'll have more indeterminate positions and fewer relief positions that are filled by agency nurses and casuals. But maybe Mr. Van Overloo might want to add to that.
Mr. Van Overloo?
Thank you for that. I think there are primarily three things that set us apart. As an aside, 15 years ago when I came to the North, my first job was to go out and recruit health and social services workers, and I was the one at those recruitment fairs. And the experience and the feedback that I had was people wanted an expanded scope of practice. That was the biggest driver, both from a physician, and we primarily sometimes talk about Stanton in a hospital base, but when we think of our community health centers, it's the expanded scope of practice and really feeling like you're a member of that community. I think from what I've heard from those recruiters that have been out more recently, that is still there, but they're also looking for the flexibility, and they have many more options available to them. And so obviously having incentives to draw them here and attract them here is important, but more importantly is how do they integrate within the workforce as well as within the community. And so I think some of the initiatives that we've done at the operational level, again, with the support of our partners around primary health care reform and some of the changes that we're hoping to test and pilot, those are looking at different models of staffing that are unique not only to Canada, possibly within those program areas as well too. We're also, we have to invest more in technology so that we can allow the information to move instead of for the patient and the individual to move. And so there are opportunities for us in the NWT to really be a leader in those areas. And then, as I mentioned before, the care pathways. So again, what we have is an ability to more efficiently move individuals across the organization for care. And what that's going to do is going to allow individuals that work in our facilities to start to build better relationships with their patients and clients, which is going to lead to better care. And actually better care and feeling connected to your patient and client leads to employee engagement for our staff as well too. And so I think, you know, if I'm out there, and I am to friends and families when I travel, is, you know, I'm using those three drivers, and I think that sets us apart. But again, we're at the threshold of actually actioning a lot of these, and I think the next couple of years will be really important as we start to drive some of these changes and learn from these small tests of change that we're delivering in specific areas around these three areas as well too. Thank you.
Thank you, Mr. Van. Over next on my list, I have Emily Knockleby.
Thank you, Madam Chair. I know I keep trying to make my cousin move up here. She's an emergency room nurse, but so far I haven't lured her up. My question has to do with sort of jurisdictional scans and looking at other areas where, you know, there are other populations that have been doing this kind of remote healthcare work. And I'm thinking of the NUCA system of care, which I know the department has mentioned before. And so I'm just wondering, you know, we are limited in our capacities. We always talk about not reinventing the wheel and looking to find places where things are already working. And it seems from looking at their website that they're very well set up. They've won some awards. So if the Minister Department could speak a bit to jurisdictional scans, maybe what systems we're looking at elsewhere and how do we incorporate those into ours so we can take lessons learned by others and not have to learn them ourselves the hard way first. Thank you, Madam Chair.
Thank you very much, Emily Knockleby. Minister?
Yeah, thank you. I'll ask the Deputy Minister to answer, please.
Thank you very much, Deputy Minister.
Thank you, Madam Chair, and thank you for the question. The piece around NUCA, I think, is a really important point. It speaks to the foundation of our primary healthcare reform. So we have looked at NUCA. We've looked at a variety of other models. There was also the Tabor model, which was down in Alberta, particularly around the electronic medical record. The piece that I think is really important is that we look to other models and keep an eye on what's happening in other jurisdictions, both within the country and outside of the country as well, to other jurisdictions within the world. But what we have learned is it's not a cookie cutter approach. So it's really not about, while we can look to those models, it really isn't about just taking those models and implementing them here in our territory. So for primary healthcare reform, as an example, we have drawn on NUCA. We continue to have staff go over there and learn more about their system. It's well established, but we take that foundation and then build upon it based on what we know within our own jurisdiction and what we hear from our own clients. So the short answer is yes, we look to other jurisdictions to sort of help form what our model of cares will look like, but ultimately we still believe that there is an NWT model that is unique to us as well.
Thank you. Emily Knockleby?
Yeah, and I appreciate that. I mean, I think that's what engineers do. We take lots of bits from things that work and we bring it together and try to make a bigger, better model and not have to, work ourselves to the bone doing so. So I really appreciate hearing that it wouldn't just be taking something somewhere else, trying to make it work here, but taking all the best from the different pieces. So I guess more just of a comment there. Yeah, I'll just leave it at that. Thank you very much.
Thank you very much, Emily Knockleby. Emily Summer.
Yeah, thanks. And thank you for the presentation. Sorry, I showed up a little bit late. I was stuck at Boundary Creek for 6 hours. Just for, I think we all know that the driving factors are all the things that we can't control. And I'm even worried to see the next year end after medical travel with this year's I think what we have 10,000 people at least that live in the Beaufort Delta and the Sawtooth, and those all travel on Canadian North, and those prices doubled this year, and I know that you guys still have to use the government rate, so that's going to be significant, because I think the one thing that I wanted to really see, I know during COVID that we really upped our game with phone consult and virtual appointments, and I think, I know there's always that time, and I know a lot of our elders in our community, the way that they want to communicate with their practitioners are face-to-face, because but there's a lot of people that would benefit from virtual, and I'm just wondering, that would be a lot cheaper than flying every single person into the doctor, into the specialist. And the other thing is follow-ups. I don't know how many times that I've had people come up to me and say, I had to fly all the way to Edmonton, and the doctor just asked me how I was, and I said I was fine, and they said, okay, well then I don't need to see you. But we don't educate our physicians in the South that we go to see on follow-up. They just see you as a patient, they don't know where you're from, and they just go, okay, I need to see this person, and they send it to medical travel, and medical travel books that follow-up, and it flies you all the way back. And and some people, it's like if you're in Ulahuktuk, it's 2-3 days, and 2-3 days back home with an escort. So I'm just wondering, even our own physicians, because we have so many locums, and our own nurses that we have there's so many locums, how are we doing this better? Because I think has that been reviewed, as a cost saver? I think there's a few questions in that. Thank you.
Thank you, Emily Semler. Minister?
Yeah, I think some of this is part of the care pathways that Mr. Van Oorloo was talking about, is strengthening those. He talked about the efficient movement of patients, and so I think that includes making the appointments meaningful and not just, hi, how are you? So maybe, I don't know if Tim wants to expand on that, and maybe then the Deputy Minister. Thank you.
Minister, Mr. Van Oorloo?
I think there's two aspects to this. One is what we're just talking about, the Referral Pathways Project. That's primarily focused on our early learnings through doing a case review of several of the medical travel and med response cases, and recognizing that there could be more efficiency and more appropriate travel for that care. And so part of the referral project is actually looking at wait lists, looking at our current care pathways, as well as looking at initiating collaboration with our partners outside of the NWT with Alberta as well, to ensure that we're getting information back in a timely manner. The second aspect to this opportunity is the training and the support for what we know is always going to be a transient physician practice, and even other staff as well too. And so we've had just recently feedback directly from patients and clients related to events that have happened in our organization that have triggered the need to have more standardized training and onboarding related to all individuals that come into our organization, but primarily those that are coming for a short period of time. So we've done quite a bit of work on our orientation. We launched a new orientation platform for all employees, but the challenge is we have so many people coming for shorter periods of time. And so the two things that we'd like to see is, if we can't have individuals stay permanently, that we have reoccurring locums and reoccurring casual staff so that they can start to create relationships and they can onboard more effectively. But also, we're looking at opportunities for taking current learning modules, whether it be cultural safety or learning specific to your operations within your program, and shortening them and allowing tools so that they can get delivered quickly and efficiently. And it's not going to solve all problems, but it'll start to allow us to have a better connection with those clients and patients. And then I think the last thing, if I can, is the transition and movement of information. And so we're embarking as a system. We have old systems through our EMR and through several other systems. And there is an initiative across the organization through the department that are supporting, looking at an opportunity over the next several years, where can we create improvements in those systems and get new systems. And one of the key feedbacks from staff is we want to ensure that anything that goes outside of our system is easily coming back so we can have those connections. And again, primarily those are our partners in Alberta, but that happens within our system as well too when you're coming from a smaller community into a hub, whether that's Inuvik or even Stanton and Yellowknife as well too. So I think those three things are really where we're going to see some cost savings, because it's going to minimize travel, but also we're going to have more efficient care that's going to happen as well too. Thank you.
Thank you very much, Mr. Van Overler. Deputy Minister.
Thank you, Madam Chair. I will just add a couple of points. We've been able to, the NTHSSA has actually been able to begin to use, in relation to the care pathways, some of our longer-term physicians who are maybe no longer working in the Northwest Territories or only coming back for a period of time, as an example. So some of those physicians are actually conducting and providing good examples of how we can move forward in relation to virtual care. And some of that has been primarily at the Yellowknife region, but looking at, I think that work will help inform it across the territory. I can't help but give a plug for 811. So our new initiative in November is completely virtual and is provided by PhoneMed, and there's a variety of statistics around how, and the feedback that we are getting from clients around how that has been helpful to them and have prevented them from either going to a health center or going to the emergency department. So that in and of itself, I think, has been quite helpful for clients as well as the system as a whole to support, particularly our areas where they are at reduced services at times. And then the third point that I would just add is that the modernization of the Nursing Profession Act, there are pieces in there around virtual registration and being able to therefore have nurses that are part of the RNA-NTU, or the new name for the Nursing Association going forward, to have a virtual register. And so those are areas where, again, having virtual care and the things that we learned even from COVID have continued to expand and to inform our systems, and ultimately will help improve with efficiency. So,
Thank you very much, Deputy Minister. Emily Semler.
My next question is not necessarily on this. It's more so for the, since we have the chair of the health board, it's more for that because I think from the Beaufort Delta, I've only been familiar with that council, and it's been struggling, and I know I've gotten many emails on how, to try and recruit members. And I know that, when the NWT, like when we went to One Health Authority, the idea was that each region would have their voice, so that way healthcare in their region, they'd have a voice there. But from my feedback that I've received is that that voice is not transmitting to where decisions are being changed. And I'm just wondering, I know we have a new chair, and and I'm just wondering if that, how does that message flow? Because I think if we're talking about, cost reductions, first thing people are going to worry about is it's going to get worse in the small communities. It's going to get worse in the regions. Yellowknife's always going to be okay because it's centralized, right? And so I'm just wondering how, because this is where the boards are not, they're not getting chairs, they're not getting members, so that voice is not being brought to the main table, to the chair, to being able to bring to the minister and deputy minister. So I'm just wondering how that relationship has come over these years, because, you know, I just saying, like, from the people that have sat on it that choose not to go on it anymore, they just felt like we said everything that we could and it never gets passed on, and it ends at the meeting and that's it. And so, you know, and they bring them up at the territorial meetings, and, you know, sometimes I remember hearing that one of the members asked the minister if they ever get their and they were like, no, we never got anything. And that was not this minister, but, you know, and it's just kind of like, how do we have our voices going through so we can drive change? And if we're going to drive change and being more efficient and trying to deal with a huge deficit, I mean, that was the driver of why all of these boards got torn apart, right? Was because of the deficits, and we had all these people appointed and the boards were dissolved, and now we're driving this deficit even more, and it's this big super board that was supposed to fix it all. And now people are feeling they're not heard. So I just want to figure out if this is the right way to pass the message on, and if it is, with a new chair, how does that message get passed on and changes get made? Thank you.
Thank you, Emily Semler. Minister?
Thank you, Madam Chair. I haven't heard before that the boards were dissolved because of the deficits. I think that the self-governing structures that were in place for the health authorities were often not working because they were in the hands of a publicly appointed administrator. And so the idea of creating the regional wellness councils was actually to strengthen participation at the regional level. What I have seen in the time that I've been minister is that the regional wellness councils are mostly staffed, with the exception of the Beaufort Delta, where we're still looking for members. What they have primarily done is funneled complaints into the health system, but not solutions. And so we appreciate hearing about the complaints, but it would also be helpful to know from that grassroots level what they think the solutions are. And so my attempt to deal with this was to provide a mandate letter to Jerry Cheesy, the new chair, and to ask him to do real work on solutions, such as the deficit reduction plan. And fortunately, he's the right person for the job. He's taken that on and rallied the Leadership Council. But I would like him to talk more about this, because I'm sure he hears the same that I do, that people feel that they aren't heard.
Yeah, thank you. August 23 of last year was when I became appointed to the chair. My background previous to that is I worked in Aboriginal governments and also worked for the government of Northwest Territories in the Housing Corporation. I grew up in the North, and I've been educated in the North, and I worked all my life in the North, and I have a family, and I have grandchildren. I wanted to say that because what other families are experiencing, I've experienced myself. And just to the table to try to help our council is a very diverse council. They come from a lot of different backgrounds, but they're all come to the table with one idea, that is to try to find solutions to our healthcare issues. And it's complex. The learning curve that I've been on in the last year has been very, very steep. And I'm getting to understand healthcare is not just one solution. There's so many factors involved. the remoteness of our communities, the cost of travel, the lack of physicians and nurses, all play a factor in how our healthcare is delivered. And all of our members on the Leadership Council experience that, and they bring it to the table. One of the things I've attempted to do as my time as chair is to go back into history. We're 8 years old. Of that 8 years, 3 years was in COVID crisis. So that kind of hindered our progress in certain areas and has caused major deficit issues as well. We're trying to do some good things. One of them is that we talk about recruitment and retention, and that's all based in the South. We're trying to do work now through our sustainability plan to try to train and develop local people in our regions so that we don't have to go south to bring a nurse to our isolated communities. Why can't we find in the isolated community one person or two persons that we can invest in to provide what we bring in the southern expertise and to do? I think we failed in that task, and we're trying to fix that problem now. And you know, it's something that we have to recognize, and we have to do that. The problem of medical travel, again, is a major problem to us because we were not getting funded for it adequately. And we don't have a say in how the policy is administered, because once it comes from Ottawa, they spell it out in the agreements that of funding that this is the way it has to be done. And we look at what Nunavut's doing, what the Yukon's doing, you know, and we're trying to figure out what the solution is, and real concrete solutions. And we have a good staff at NTHSSA headquarters. I can say that because I worked with them in the last year, and I've grown to trust them. The other thing that we're attempting to do, and which is a positive thing, and we've just done it this year and just recently, is that we have a patient advocacy department in our function. And you talk about like sending a patient to Edmonton for the doctor to say, how are you doing, is ludicrous in my mind. The advocacy group can talk with these people, the elders, and relay that kind of information to the physicians, so that we don't have to, you know, send somebody from, like you say, 6 days travel to turn around and go home with nothing really new to changes to their health or their health care plan. So we're trying our level best to try to improve the system. And I'm not under any illusion that I'm going to change it in my term. I graduated from high school in 1970, and I worked my entire life in the NWT. So I know what's going on in the north. Been involved, like I said, with Aboriginal governments, and so I know a lot of people, and I use these contacts to help me try to find solutions and keep the doors open for communication because that's one of the things that I think we're lacking is we don't have a really good communication plan, but we're doing that. We're doing that now. And so I hope by the end of my term that we'll have better information to provide to you or to the other people that might be coming after the next election. You know, that we can actually tell you more concrete examples where we can improve things and where, you know, have a plan. And I tell you, like, from the leadership members, they're all caring individuals. And some of them have been there 6 years. And so that tells me of their commitment to this process. And we're talking about at the leadership council level that, you know, we're looking at the creation documents. We're looking at all these things because the stronger the leadership council is, the more effective NTHSSA is going to be. And so we're not just sitting there, and I'll tell you right now, and I've told this to the minister, if she wants somebody to rubber stamp stuff, well, she got the wrong person. Because I believe in positive change. And that's why I put my name forward and I was honored to be selected. So I want to do my level best to try to move the ball down the field in an organized, effective way so that I can improve healthcare for all of our people. You brought up NUCA. I attended their conference this June. I went to Anchorage, Alaska, and saw firsthand what they're doing. And it's amazing what they're doing. If I could do that, I would try to bring it and drop it right here. But I can't for various reasons. One of them, it's a tribal-run organization, separate from government, although they get government funding. But what they've done in 25 years is amazing. You know, their clientele is a population of about 65,000. Ours is 40. And when I look at that and I say, well, why can't we do what they're doing? You know, because they've managed to develop a system that works for them. And that's what we're looking for here as well. And there's a lot of questions that the MLAs have asked which are valid, like why is River separate? Like, and I ask those kind of questions too. But some of this is historic. The reasons why it was done that way. And again, like I've learned the hard way that I can't run around trying to put out fires everywhere. That we got to have a plan, and we got to go with that plan, and trust the plan. And so I want to try to impress upon the committee here that the Leadership Council takes her work seriously. We're not just sitting there twiddling our thumbs and collecting honorarium. We actually want to do something that's going to contribute. And that's why I think the Super Board was started. And I certainly, you know, at the end of 3 years, you can ask me again, you know, and I'll be more than candid with you, because I don't believe there's any other way. The health care of our people is so important that we got to find this solution together. And so I want to leave it at that. Thank you.
Thank you very much, Chair Cheesy. Next up, I have questions from MLA Bonnet Rouge online.
Merci, Madam Chair. There's a ship called the NTHSSA that's lost its rudder back in 2016. It fell off, and only now they're letting us know. This is very concerning to us in the small communities. We're facing perhaps a health crisis. But many issues. In the 4 years I've been here, I've been harping on those issues. No one from NTHSSA ever approached me to talk to me about it in that time. We lost many of our people. Because there's no capability to diagnose the early detection of any of the cancers and other chronic illnesses. It's not because of just the lack of equipment, it's a lack of compassion or care. Because they've been, like I've been saying, they go to the health center 3-4 times, they're just sent home with a Tylenol. Isn't that concerning? Doesn't anybody from the higher up say to that health center, hey, what is going on here? Nobody's done that. That's why I've been asking for evaluations of these health centers and patient records, where we could get to the bottom of the problem and the issues. And it's all in the news, all over social media, that this is going on. In the 4th year, we're down to our last 16 days. There's still no solutions out there from this department. I don't know when's the last time that NTHSSA ever reported to the public about their accumulated deficit. It's the first I've heard of it or meeting on it in the 4 years I've been in here. And I recall that the Liberal government were dangling, I think it was a healthcare financial plan for all the provinces and territories that perhaps or probably could have bailed us out. But the premiers rejected that plan. I'm just hoping that the minister that's in attendance here can apprise us as to that deal, which perhaps could have provided us much needed financial resources or professional health workers. Merci.
Thank you, Emily Bonnet Rouge. Minister?
Yeah, thank you. Thank you for the points. NTHSSA has been in the community in the time that MLA Bonnet Rouge has been the MLA to talk about the qualifications of staffing in the health center. And that led to a follow-up from the Registered Nurses Association of NWT in Nunavut and was resolved. The health centers are accredited, and there's another accreditation cycle starting in the fall, which I'll ask the Deputy Minister to talk more about. The NTHSSA produces an annual report and has an annual public meeting that takes place in September of each year, where they report not just on their audited financial statements, but also about their initiatives. The premiers, when they met after Christmas, said they would help the Northern Territories to obtain more money from the federal government. And although we followed that up and lobbied, we were not successful in getting any additional money. We got a commitment that the money would last for 10 years, which wasn't really what we were after. But I want to assure you that that I have and my staff and the Premier have all worked very hard to try and get more operating money from the federal government. And we have had some success, but we could certainly always use more money. But to talk about the accreditation, which I think addresses your issues around the training of the staff and the care they provide, I'd like to ask the Deputy Minister, please, Madam Chair.
Thank you, Minister. Deputy Minister?
Thank you, Madam Chair, and thank you, Member Bonnet Rouge, for your questions. First of all, I'd just like to, there's two levels of what we would probably consider accreditation. So within the Northwest Territories, there are programs and standards, and I know your questions was specific to nursing, so excuse me, I'll speak to that. So there are programs and standards for nursing in the Northwest Territories, and in particular for community health nurses. And those programs and standards exist for all health centers across the territories. And particularly if we're talking about the DECHO, like other regions, the health authority provides routine audits of their programs and services, and they go into each of those health centers X number of times per year, and they report on within the health authority and the administration around how the nurses in particular are meeting those programs and standards. And so that's one area of accreditation whereby we would just say that there is a mechanism to identify whether care is not being delivered globally across our system according to various standards and protocols and processes and policies and such. The other level of accreditation, and if you would like more information on that, I could ask the NTHSSA to speak specifically to this, but it's a Canadian standard, and so there are accreditation policies and procedures whereby the National Organization for Accreditation Canada comes into the organization such as NTHSSA and audits for all intents and purposes. We'll call it an audit, but it is a mechanism where there is a review, there's an assessment done for programs and services, and health centers are part of that process. And so the NTHSSA has been accredited, and they are embarking on this fall, I believe, is their renewal and review of their accreditation processes, whereby they look at various programs within health and social services, and as I mentioned, health centers are a part of that. The last part that I will just mention, and sometimes we call it accreditation or credentialing, of course, is that nursing is the only self-regulated profession in this territory, which is regulated by the RNA-NTU. And so health profession is my point around the only self-regulated health profession in this territory. And so RNA-NTU does regulate the nursing profession. And as the minister said, in the DECHO, there was an incident there whereby there was a review done. So I'll stop there and pause there and hand it back to the chair.
Thank you, Mr. Ticado. Mr. Bonnet Rouge, do you have a follow-up?
Merci, Madam Chair. Yeah, thanks for all that and the accreditation. I guess it was there in place before for the last 4 years, and nothing was really done there. People were falling through the cracks majorly. You know, you gave out probably, I don't know how much Tylenol you gave out to our people. Well, I really hope to see something there anyways. You mentioned these different organizations within or besides the Department of Health and Social Services, because now there's the Northwest Territories Health and Social Services Authority, and we also got RENATNU, which is the Registered Nurses Association of the Northwest Territories and Nunavut. And I was kind of having problems with it at the beginning. I know we did resolve an issue, but I never had or heard of NTHSA's hand in that resolve. I've only worked with Renat New at that time. So I'm wondering what's what's the relationship between all these three groups? Like when I questioned the minister on the floor, she says, "Oh, they don't handle this. You have to ask these guys." So, you know, and I've always been at the view that the department, you know, is supposed to represent the residents of the Northwest Territories. And they should be able to answer questions and also direct their inquiries to the NTHSSA, to every health authority in the regions, and to RINACNU. But it doesn't seem to work that way. So it's kind of like all splintered and everything. I'm not sure if that's what's leading to this deficit, but I don't know what the relationship is, whether anybody can really answer to what I'm trying to get at here when we pose a scenario to the department. I'm just wondering if anybody could perhaps touch upon the relationship of all three and whatnot, Masi.
Thank you, Emily Bonnet-Rouge, Minister.
Yeah, thank you. Thank you for your question. Until 2016, the Department of Health and Social Services both delivered healthcare and created all the policy and legislation framework and oversight. But starting in 2016, NTHSSA, along with Hay River Health and Social Services and Cleto Community Services Agency, took over the delivery of healthcare. So NTHSSA delivers the healthcare. The department oversees the delivery of the healthcare. And the people who work in healthcare, the nurses, belong to a professional association called the Registered Nurses of NWT in Nunavut. As you know, you've had dealings with them in the past. And the doctors belong to the NWT Medical Association. So those are professions that the nurses have their own regulatory authority. So this is a complicated system, but basically the healthcare delivery, what you're getting in Fort Providence is delivered by NTHSSA, and it's delivered by people who are licensed to perform the care by RENATNU or by the Department of Health and Social Services, who takes care of the physician licensing. So it is a complicated system, but it is it's a system that fits together and hopefully provides seamless service to the patient who's not worried about whether people are licensed. They have to be licensed. They can't practice without a license at any level. Or about who's writing the policy and procedures. The department's doing that, but that should not be a worry that the patient has to take on. What I hope they are receiving in Fort Providence and health centers throughout the territory is a direct interaction with a qualified nurse, a community health nurse, who is listening to them and trying to resolve their issues. Thank you.
Thank you very much, Minister. Next on my list, I have Emily Ajercon.
Thank you, Madam Chairman. I just want to speak to the subject matter that we're talking about tonight, and it's on healthcare and the services you provide to the residents of the Northwest Territories. I just want to make a note that when I was first elected to office on February 10th, 2023, I have taken an oath to the Legislative Assembly, and it says, I'll just read it off of the record. It says, I, Richard Ajercon, do swear that I will be faithful and bear truth, allegiance to Her Majesty, the Queen Elizabeth II, Queen of Canada, in her heirs and successors, so help me God.
Jericon, I'm not sure if you can hear me, but we seem to have lost your audio.
Can you hear me?
Yep, we can hear you now. Go ahead.
Okay, I'm not sure if you heard what I just read out.
Yep.
Okay, so what I did is I just read out my the oath of office. Did you hear me uh, speak to that?
Yes, we did.
Okay, thank you, and I'll just continue on. Also, I have in front of me a Treaty 8 document, and this document talks about the treaties that was made with the Queen of England, honor of the Crown, and the treaty that my great-great-grandfather signed on July 25th, 1904 resolution. And his name is in here. His name is Oliver Jericon. And so I guess what I'm trying to say here is that, we have the medicine chest that speaks about the treaties. And going forward, what's concerning to me, though, is that this responsibility of the medicine chest was handed out to the provinces and territories. And so when I read out my oath of office, it speaks clearly that I will honor and respect the treaties and sign with the people. But yet at the same time, the government of Canada, through the territory transfer agreements, through grants and contributions, they have $1.6 billion in that area. And that covers a wide variety of everything, but healthcare is one of them. And but yet at the same time, when I hear on the news that we're having trouble with the
Emily Jericon, I'm not sure if you're able to turn off your video, but your audio seems better when your video is turned off.
negotiate claims in the north, and then we hope that governments could respect that. But when the territory government says yes, I'm happy you're doing it, but next thing you know, here we are, we're going to be going to court or finding ourselves in this process. But anyway, I guess what I'm trying to say is that I only hope that the territory government can really respect and honor those treaties that I just mentioned. We got the IRC, got the Gutchin, Sawtooth, Clucho, Decho, Quechua, and the Métis as well. But at the end of the day, it's concerning that we're still dealing with medical travel issues, health issues in our communities on a daily basis. And I got another one tonight that I'm trying to reach the minister on, but I didn't realize she was there. But anyway, we'll deal with those issues probably a little bit later on. But for me is that what's missing in your presentation is what I notice is that we're not doing enough to really address some of these outstanding issues. And I really like what Jerry Cheesy talked about, and I agree with him because he's a northerner, and I see I'm also hands-on in the community. I was a former leader, and I hear what's been said in the communities, and we got to take it pretty serious. But at the same time, we got the biggest budget in government, and healthcare is the biggest budget we have. And yes, I'm really grateful for the services that's been provided by your department and all the people that's working in that department. And it's, my head goes off to all the frontline workers during COVID and post-COVID and so on. But, just you and I, we could just take a drive down the streets and we could see what's going on. I don't see anywhere in your presentation that talks about the Royal Commission report, the Indian Residential Day School, the Federal Day School, the institutions that we have are a majority of Aboriginal people. And somehow, and I mentioned this in the Legislative Assembly and also mentioned this to the Premier, is that, as a government, and we got to find a new way to really get Government Canada on side, because at the end of the day, A lot of the problems that we see here in the Northwest Territories are stemming from, as to how the kids were treated in Indian residential school and federal day school. And that's something that needs to be talked about. But at the same time, we got
MLA Jericon, I'm not sure if you can hear me, but if you can turn your video off, your audio seems to be better when your video is off.
at the end of the day, government has have to hold on that responsibility. And we can't let this one go because, the ball's also in their court. But anyway,
MLA Jericon, we seem to have lost your video, or sorry, your audio. Are you able to hear me okay?
can you hear me?
Yep, I can hear you now. Are you able to ask your question to the minister while we still have your audio?
Yeah, just to speak. To hear me?
You're breaking up quite a bit and your audio is dragging a little, but if you could try and succinctly ask your question to the minister, we might be able to capture some of it.
Okay, so thank you for that. And I tried to summarize what I just said earlier. One is the oath of office that talks about the honor of the treaties, and the other one is that the $1.6 billion we get from Government of Canada through grants and contributions, another factor that covers off healthcare as well. And at the same time, the problems we're having here in the north are the social problems that are impacting the Aboriginal people on the streets and in our own institutions. So, we have the Royal Commission reports that made a lot of recommendations. We have the Indian residential day school issue that's been plaguing our people for a long time, and the federal day school system. Yet our jails are 95% full. So the two things I guess what I'm trying to say is that, and I did bring this up in the House, is that we need to figure a way. We know what I've been hearing in the presentation, and I heard the minister talk about this before, is that we just don't have enough money. So going forward, I think we're going to have to look at somehow in your presentation to get the government of Canada
MLA Jericon, we seem to have lost your audio again, but I believe what MLA Jericon is leading to is additional funds from the Government of Canada to address the adequate needs of healthcare in the territory.
So we need to make sure that we get the government of Northwest Territory through the health system, is to probably go after Government of Canada for more resources to fill the gap in this area. So anyway, two things. One is that the government of Northwest Territory must continue to respect the treaties on the medicine chest, and medical travel and all these other issues have to be part of that, and there has to be a solution to that. And anyway, and then the last thing I just want to point out is the funding again. It's very important that we go after additional funding needed to deal with these issues we're facing right now in our communities and through the Northwest Territories. Masi.
Thank you, MLA Jericon. Minister?
Thank you, MLA Jericon. Of course, the GNWT honors the treaties. This is something that we all commit to. We all take the same oath. The GNWT provides a public health system. It helps all residents of the NWT, whether they were born here or they've been here for 3 months, whether they have a great-grandfather who signed a treaty or they have a great-grandfather who lives in another country. So we are trying to provide an equitable health system to all residents of the NWT. This is a primary concern of ours. And having the federal government provide more money, particularly for NIHB, is key to making the system more equitable. And I want to assure you that the Premier, her staff, myself and my staff have worked tirelessly to try and extract more money from the federal government to address our healthcare needs, because what we have now is not equitable. The health outcomes are not equivalent to Southern Canada. And the largest health system in this country is operated by the federal government with respect to NIHB and benefits for federal workers. So this is something that the next assembly will have to continue to lobby the federal government for additional funds to provide health that is on par, healthcare that's on par with every other part of the country. Thank you.
Thank you, Minister. And I think that based on, the fact that we've been here now asking questions for, onwards of 3.5 hours, that healthcare is very important to the entire Assembly and to the residents of the Northwest Territories. And so I think it's safe to say that you can definitely expect additional questions on the floor of the House, just so that members of the public know. The next sitting of the Legislative Assembly starts on August 16th, which is just around the corner, and it will be a 7-day session to wrap up the end of the Assembly. So with that, I want to thank both yourself, Minister, and your staff, as well as the Deputy Minister and staff of the Department of Finance. And I'd like to pass over to Chair Cheesy to close us off this evening.
I'd like to address this issue of NIHB. Since I've become chair of the Leadership Council, I've been advocating that we have a shared partnership, an actual quality shared partnership with Aboriginal governments. When we talk about NIHB, I'm just that non-insured, whatever it's called, we should be at the table. By we, I mean the Aboriginal government should be at the table. And not this group that the minister, not the minister, but the government leader has gathered of northern leaders. Because of that one, there's a bunch of people that are, two regions that are left out of it. And business can't be done like that. And why I'm saying that to you is because you guys are MLAs. You guys are the people that can affect that change. I think it would be very beneficial if we had chiefs of our First Nations at the table when we were talking to the Minister of Health in Ottawa about medical travel, about the lack of funding we're getting. Because they're not getting the message. And I've been the chief in my past, and I know they don't get the message in across all kinds of programs. And the pressure that you have to bring upon them is going to have to be not just by the MLAs or the ministers of our Legislative Assembly, but it's also got to be done by the elected leaders of the people in the regions. We have constitutionally protected agreements with the Inuvialuit, the Gwich'in, the Sahtu, the Clicho. So we're tied at the hip with the federal government. Let's use that to benefit our negotiating position. I think it would be immensely positive if the Legislative Assembly would share the load of carrying this healthcare forward. And because we do have two treaties here, 8 and 11, and also this constitutionally protected agreements. To ignore that going forward, I think is detrimental to the growth of our territory. Because all of us got to carry the load. Thank you.
Thank you, Chair Cheesy. Really appreciate that. And I think that those are wise words, not only for this assembly, but also the next assembly and residents of the territory to support that work as well. So thank you very much. And thank you for being here today. I really appreciate it. I'd like to also thank the minister and staff, as well as the Department of Finance earlier who joined us as well. And would also like to thank members of the public who have joined us here this evening for this presentation. And again, session starts on August 16th. Merci.